Yes, hello. My name is Rahul Aggarwal. I'm a GU medical oncologist at the University of California, San Francisco. So this study was conducted in patients with prostate cancer who had prior radical prostatectomy for surgical treatment of their localized disease, who subsequently had a rising PSA, what we call biochemical recurrence, and a short PSA doubling time of 9 months or less. This is a group of patients that's at high risk for the development of distant metastasis. And these patients could not have any evidence of metastases at the time of study entry. So this was a biochemically recurrent prostate cancer population. Patients were randomized to one of three arms. Patients were treated either on the control arm with single agent androgen deprivation therapy. The second arm, experimental arm, was ADT plus another investigational agent called apalutamide, which is an androgen receptor antagonist. And then the second experimental arm, or the third study arm, was ADT plus apalutamide plus an additional androgen synthesis inhibitor called abiraterone with prednisone. In all three arms, the patients were treated for a finite treatment period of 52 weeks and then followed until PSA progression. PSA progression-free survival was the primary endpoint of the study. And the main findings of the study were that in both experimental arms compared to control arm, the addition of the additional hormone agents, apalutamide, and in the second arm, the combination with the triplet, both experimental arms extended PSA progression-free survival compared to control with a hazard ratio in the 0.5 range. So with the doublet, with apalutamide plus ADT as compared to ADT alone, it looked like the combination was well tolerated. The frequency of grade 2 or higher adverse events was comparable between ADT alone and ADT plus apalutamide. In contrast, when we see the further addition of abiraterone, we do see a higher incidence of particularly hypertension, which is an expected side effect of abiraterone. So the rates of grade 3 adverse events did increase with the triplet, and there was a little bit higher rate of other adverse events, including liver function test abnormalities, low potassium, and so forth. None of it was really unexpected. There was no new safety signals, but with the further addition of abiraterone, we did see more toxicity with the triplet. So I think that we need further follow-up to really understand the impact of combination therapy on longer-term endpoints, including metastasis-free survival, time to castration resistance, time to subsequent therapy. However, I do think that for select patients, because we often make treatment decisions in this setting based on the PSA kinetics alone, for select patients with a very short doubling time who don't have a lot of comorbidities, I think it is reasonable to offer the doublet of ADT plus apalutamide for those patients with the thought that we treat for a finite period of time, then we can suppress the cancer and delay the time until there's subsequent PSA progression, at which point further testing and treatment is often done in this setting. So I think on a case-by-case basis, we can use these results, but for broad practice-changing change to our paradigm in this setting, I think we do need longer follow-up and assessment of metastasis-free survival is one of them.